Okay, well, welcome everybody. Thanks for joining this. This is our second webinar in a series of webinars that we started. And I'd like to first of all introduce Mary Garthwaite. Um, Mary is a former urology consultant and is currently the chair of Urology Foundation. So very busy lady. So thanks very much indeed for taking the time to help us out, Mary, on this one. Very much
It's a
appreciated.
pleasure.
And also Helen Lake. Helen is a stoma nurse, working part-time, I think, with Urology Foundation now, Helen. And we were just talking earlier about Helen being trained by a lady called Eileen Spraggan, who's been involved with the UA for many, many years. Unfortunately, Eileen's not well. She's in hospital at the moment, but she's hoping to go home very shortly. We are recording the session this evening, and it'll be put on the UA website as soon as we can afterwards. So I hope that's okay with everybody. If anybody's got any problem with that, if they could let Samantha know. Um, but we hope to do that. Um, and we'll take questions at the end of the presentations rather than during the course of them, so it doesn't interrupt the presenters. So if you could put those in the chat, that would be great. So on to the first presentation then, which is Mary, please.
Super. Thank you ever so much, Brian, and thank you very much for inviting Helen and myself to join you this evening. It's fantastic to be able to support what you do. I'm going to now share my screen, and also then so people can see a presentation that I've got. So please tell me if anyone has a problem seeing that.
Yeah, all is good.
Wonderful, thanks, Scott. So I'm going to talk for about 15 minutes and then hand over, but I'm around for the whole webinar and I'm very happy to take any questions at the end as well. Samantha and Brian asked me to talk about urinary tract infections and obviously their sort of particular importance in terms of people living with urostomies. And this is an area of urology that I dealt with throughout my career. And I had a career-long interest in urinary tract infections in general. So I'm going to talk a little bit about diagnosing a UTI when you have a urostomy, knowing what symptoms can be, and then talk about understanding the limitations of the medical terminology that's used and the different definitions, because a lot of the research work that's out there and the medical work is around UTIs in people who still have functioning bladders, and that makes it difficult to use and interpret when dealing with urinary tract infections in urostomies. And that leads nicely onto sort of being aware of the pitfalls in assessment and interpretation of results. And this can lead to an awful lot of frustrations all round, both for the individual themselves, but also the medical team looking after them. And then talk a little bit about a plan of action, so how knowledge and empowerment can help you if you're struggling with urinary tract infections. A brief look through all the treatment options that are currently available, and then just a few final thoughts. So in terms of urinary tract infections, there are a number of risk factors that are specific to urostomies. So the main one, the big one, is the fact that urine now passes through a segment of bowel, and bowel is not sterile. So there's a constant bacterial threat that has been introduced to your urinary tract when you have an ileal conduit or any type of conduit using a segment of bowel created. And that leads to a paradox, because bowel mucosa, so ileal mucosa, is what we call bacterially tolerant. Your bowel is designed to house myriads of bacteria without them causing a problem. They coexist and get on quite happily. Whereas in your urinary tract, the lining of the whole urinary tract, which includes the ureters up to the kidneys, is not used to having bacteria living alongside it, and is therefore incredibly immune active. And it's basically evolutionarily created a mechanism by where it literally goes out of its way to seek out bacteria and sort of attack them and clear bacteria and destroy them. So when you put the two together and you've got a conduit, what do? What does the conduit do? Does it destroy or does it tolerate bacteria? And we'll come back to that a little bit later when we talk about people who seem to suffer with lots of infections who have conduits, but also those who don't seem to have any infections at all. Then you've got the usual anatomical, what we call the anti-reflux mechanism at the bottom of the ureters when they're plumbed normally into the bladder, which usually works to stop urine going back up towards the kidneys. Well, that's lost when you have an ileal conduit. So in normal situation, the bottom of your ureters passes through the thick muscular wall of your bladder at an oblique angle, so that as the bladder fills full of urine, the bottom of the ureters gets squashed shut, and that means that urine can't go back up towards the kidneys. And that's a very good anatomical protective mechanism to prevent any bacteria that does get into the bladder going up to the kidneys. And of course that is lost when you have an ileostomy, and therefore an ileal conduit, should I say, and therefore you are at more risk of getting bacteria going up towards the kidney. And in just sort of basic terms, the length of your ureters is also shortened. So rather than having to go right down deep into your pelvis to reach your bladder, and the ureters actually join your bladder right at the very bottom, where almost next door to where the urethra comes out to the outside world, now they're shortened because we have to shorten them so that they can join the bowel segment further up in the abdomen. And therefore they've got a shorter distance between the outside world and the kidneys for bacteria to move about. And then, of course, when you remove the bladder from the equation, you remove a lot of the classical signs and symptoms that normally act as an early warning score for urinary tract infections, and that poses its own problems. And if you add all of these factors up, it really just amounts to an increased risk of developing often more serious urinary tract infections, so either kidney infections, pyelonephritis, but also a risk of potentially developing sepsis, which is when bacteria get into the bloodstream causing a bacteremia. And so it's really imperative that treatment is swift and effective when it's needed. Then there are general risk factors for UTIs that will still play a role. So low fluid intake always plays a role in UTIs. You need a good fluid intake to flush the system through. It literally, physically will flush bacteria down and out through the system. Poor nutrition can play a role. That can affect your immune system and how well your body can fight infections. Anything that causes immune suppression, so health conditions such as diabetes, but if you end up having to have things like chemotherapy, or there are some drugs that will cause it that are used maybe for autoimmune diseases such as rheumatoid arthritis that can affect and suppress your immune system, and they all put you at more risk of a urine infection. So symptoms of UTIs when you have a urostomy can be quite vague. So you may just have an unexplained feeling of being very fatigued. And I say fatigued and not tired because it is often really an extremely overwhelming feeling of exhaustion. You might just feel generally fluey and unwell. Sometimes you can get pain around the actual urostomy site. More often than not, though, it will be a sort of generalised abdominal pain that's quite difficult to localise. You may get flank pain on one side or both sides, or even renal angle pain, and your kidneys are tucked up underneath the bottom of your ribs. So if you were to put your hands on your sides, where your fingers are around the back, just and a little bit up, that would be where your kidneys are. You might notice sort of foul and offensive smelling urine coming out of your urostomy. There might be increased mucus production from the bowel as it becomes inflamed. You might actually see visible blood in the urine, so hemorrhagic UTIs can be more common because of the bowel segment, which is more prone to bleeding. Or you might just have uncontrolled bouts of shivering or fever, which usually suggests that you're spiking high temperatures and are a worrying sign that bacteria might have got up towards the kidneys or even further into the bloodstream. But you might have an unexplained loss of appetite or even nausea and vomiting with it. So all of those things, if you do get them, obviously there are many other things that can cause all of them, but it's always worth stopping and thinking, is this a UTI, particularly if you've got several of them together, developing together. So looking at the classic UTI terminology and definitions that medics use, we'll see how limited they are in this scenario. So if you look at the textbook definition of cystitis, it's a clinical syndrome of frequency, urgency, and dysuria. Dysuria just means sort of difficult urination or painful urination. Plus or minus, you might get pain in the lower tummy in the suprapubic area or referred flank pain. But if you don't have a bladder and you don't have a bladder that is taking urine and passing urine through it, and instead you have urostomy, an awful lot of that really doesn't seem very appropriate as a definition. Medics also talk about pyuria, which is the presence of white blood cells or pus cells, as we often know them, in the urine. And if you look at a definition of that, it always says whenever you find what we call sterile pyuria, so white cells in the urine but no bacteria around, that warrants further investigation for things like stones or cancer or TB. But the trouble is, urine from a urostomy will always have more white cells in it than urine from a bladder, again because it passes through bowel tissue. Then there's something called asymptomatic bacteriuria, which is where we find bacteria in the urine and often get a positive full culture of this, so we can say which type of bug it is. But the individual, the person who has provided that sample, doesn't have any symptoms of a UTI whatsoever. Now, interestingly, studies have shown that around 80% of people with a urostomy will have bacteria in their urine, but only about 20 to 30% will struggle with developing UTIs and even potentially recurrent UTIs. And there's a big question as to why not everyone gets a UTI and some people get really bad problems with recurrent infections. And that's an ongoing question. Professor Rob Pickard at Newcastle and Judith Hall, who's one of the scientists up at Newcastle University, did an awful lot of work on this, looking at why there is a difference between the two, and that work's still ongoing today. If you look at the definition of a urinary tract infection, it says a symptomatic inflammatory response of the urothelium, that's the lining of the bladder, to bacterial invasion that's usually associated with white cells in the urine and bacteria in the urine. But because the bladder isn't involved in urostomies, this sort of scientific definition seems a bit irrelevant. However, clinically, we diagnose a UTI on symptoms rather than on the sort of the being able to see an inflammatory response. So if there are bugs in the urine and the patient has symptoms, whether they have a bladder or not, they may well have a urine infection that needs treating. And then the final definition is recurrent urinary tract infection. And this definition applies to anyone who gets a urinary tract infections. And 2 or more symptomatic episodes in 6 months. So again, you can see that the emphasis is on symptoms, not on culture results. Or 3 or more symptomatic episodes in 12 months is the sort of research medical definition of recurrent urinary tract infections. Now, I would argue that, you know, one urinary tract infection is bad enough actually, and can be severe, and if it hospitalizes you, that's a real problem. But you know, there are some people out there who are getting many more than 3 in a year, and it can be a real struggle to break the cycle of recurrent infections. When you do get into this sort of cycle of recurrent infections, we have to ask ourselves, is this true reinfection, or is it bacterial persistence or resurgence, i.e. the bugs haven't ever really fully cleared with the last treatment course, and they've just multiplied and come back again. And that can be due to either inadequate treatment, so the course of antibiotics might not have been long enough to clear it, or they might have been the wrong type of antibiotic because of bacterial resistance, or it could be that you have an underlying infective reservoir, so things like kidney stones or stone formation within the conduit itself can harbour bacteria. They love clinging to debris and stones, and they can be very difficult to clear without actually clearing the stones themselves. So in terms of assessment challenges, well, you'll all have heard of dipstick analysis of the urine, where we do a quick dip into a urine sample, and there's lots of factors tested by those quick tests. The ones that we use to look for infection include the ones looking for red blood cells, white cells, and nitrites. But because blood cells, white cells, and bacteria will always be present in a urostomy at levels that can trigger positive readings, really dipsticks are of absolutely no use in diagnosing a UTI from a urostomy. So if someone tries to tell you you've got a UTI based purely on a dipstick urine, that's not good enough. It can potentially lead to overuse of antibiotics and the risk of even more problems with antimicrobial resistance. However, I should add that it is useful for other purposes, such as for, you know, they might be dipping your urine just to check for things like the presence of sugar or protein. So really, a urine should be sent off for what we call MCNS, so microscopy, culture, and sensitivity. So microscopy literally does what it says on the tin. Look down a microscope and you can see white cells, red cells. Casts are something that you see in kidney disease, where you might see skin cells, which if the urine has been contaminated, or you might see sort of strands of fungi and viruses, which cause atypical infections. And then culture is where we take that urine sample and we put it in various sort of growing media in the laboratory and see what bugs we can grow. And that has to be done on an appropriately collected sample. So not from the bag, which will be colonized with bacteria, but either a sterile catheter placed directly into the stoma or drip caught from the spout into a sterile container after you've washed the spout with water, and ensuring that it's drip caught and that the container isn't actually touching the stoma. So quite tricky to do, but it's really important, because it's only by doing that you'll know that if you do grow any bugs, they are truly coming from within your urinary tract system. If there's going to be a delay getting it to the lab, it can be stored in a fridge if it's in one of the containers with the special preservatives. And then if we grow bugs, they then get plated onto these gel plates in the laboratory. And these multicolored discs are each impregnated with different types of antibiotics. So we can see which antibiotics stall, halt, or reverse the growth of bacteria. And that gives you the sensitivities. So it's very tricky with urostomy urine specimens to interpret culture results, because you're likely to grow several different bacteria because they are there in the bowel segment. And it's trying to determine which is the one that's causing you to be unwell, causing the infection. So the lab will look for the usual suspects, the bugs that are known to cause urinary tract infections. And they will look for those that grow in the highest concentration, because that's more likely to be the causative bacteria. And then, as I say, they will look at the sensitivity results to try and help decipher which antibiotic treatment to recommend. The one they'll usually choose one that's effective against the most likely culprits in your urine rather than possibly just one. So you can see it's not an exact science, and culture results might alter treatment, but they shouldn't delay it. So culture results take at least 48 hours, but you can't really wait that long in case your infection gets worse. So often we start with a sort of best guess, or what we call the empirical broad spectrum antibiotic, while we await those results. So I'm a big believer in knowledge and empowerment, and I think, you know, as an individual, when any of us becomes a patient, if you understand what's going on and what's being done and the science behind the tests and how the difficulties in interpreting results, it's much easier to make decisions with your healthcare professionals and understand why they are advising certain things. So I think I listed the things that I think are really important. So why prophylactic measures? So measures to prevent the risk of UTIs are always important. So I mentioned hydration and nutrition, but it also covers good stoma care and bag hygiene. And these are things that are very easy to slip and become suboptimal, but they're really, really important. And yes, you may still need other treatment. You might need courses of antibiotics, but there's sort of no excuse for doing the basics well when it comes to anything in healthcare, really. It's all about trying to do everything we can to keep ourselves as healthy as possible and sort of out of the way of problems. Awareness of potential symptoms and when to seek treatment is really important. I think if you ever see bright red blood in your urine, you should seek advice and medical input. But if you get any of those vague sort of signs and symptoms of a UTI, you're not feeling right, then it's always worth seeking advice and seeking investigation to see if it is your urine that's causing it. But it's also worth knowing why cloudy or smelly urine doesn't necessarily mean an infection. So there's lots of reasons why urine becomes cloudy or smelly. What you eat in your diet, how much you're drinking, all of that can change the smell and the appearance of urine. So if you get that just as a solitary problem, but you feel absolutely fine in yourself, then it doesn't necessarily mean that you've got an infection going on. We've talked about how to take a correct urostomy specimen of urine and how to store it if there's a delay, and why it's pointless if a healthcare professional seems to want to do a urine dip on your urine, then it's worth politely pointing out that you're aware that it's a pointless test to do. But then, of course, there are the limitations of the culture results and why it's not always a straightforward answer as to which antibiotic is going to work. And then always be empowered to escalate care to a specialist. If you've got severe symptoms, they're getting worse, or they're not responding to treatment at home, or you're developing recurrent problems with UTIs, it's worth escalating your care to a specialist, either by your GP or by a stoma nurse specialist, or if you are still in touch with a urologist, then getting back in touch with them. So in terms of whizzing through the treatment options, if we think about non-antibiotics, non-antimicrobials, there are lots of things you can get over the counter to try and reduce the frequency and severity of recurrent urinary tract infections. You'll have heard of cranberry tablets, and there's something called D-mannose you can get. Both seem to work by reducing bacterial adherence to the walls of the ureters and also the bladder. They're not, you know, the trouble is this all comes with expense. Probably the cheapest thing you can get which helps are the vitamins. So vitamin C can limit the growth of some bacteria, and vitamin D is thought to have a positive effect on certain peptides are sort of like little molecules that are produced in the urinary tract which have antibacterial properties, antimicrobial properties. There is also something called methanamine, which is a urinary antiseptic. You take it orally and it hydrolyzes to ammonia and formaldehyde in an acidic urine environment, and that can help. The thing with all of these is none of them work 100% and they don't work for everyone. So it's a case of trying it and see which works for you and which doesn't. If we look at antibiotics, there's two sides to this. There's one which is used for prevention of recurrent urinary tract infections, and one which is used for the treatment of an acute UTI. So in terms of prevention, they're not ideal because there's a risk of bacteria in the urostomy bowel segment developing antibiotic resistance, and then if they do keep causing infections, it becomes more difficult to treat. They're often rotating or single course. There's an ongoing debate about that. They're low dose, and the duration for which you're put on them varies, but it's very sort of controversial and long debated, and still long debated in this age of increasing antimicrobial resistance. However, antibiotics for the treatment of an acute urinary tract infection absolutely are a must when they are needed, and they'll usually be orally administered, but you may need IV intravenous antibiotics if you've got a severe UTI, or if there's a risk of you developing sepsis. And it depends on the results of the sensitivity tests. Some bugs are only sensitive to an antibiotic that is in an intravenous preparation. The other thing that may happen in sort of cases of particularly of difficult to treat frequent recurrent urinary tract infections, we do sometimes instill gentamicin, which is one of those antibiotics which is in solution rather than being available in a tablet form. We do sometimes directly instill that into urostomies. And then some of you may have heard of vaccines. They hit the news recently. Well, the Euroimmune did. That's a vaccine that was developed in Spain over 10 years ago now. It's not widely available in the UK at the moment because it hasn't been approved by NICE, so it can only be prescribed off license, which means that the doctor that's prescribing it has to take absolutely full responsibility for you using it. And so at the moment you can only get it privately or via a few specialist NHS recurrent UTI clinics, but we're sort of hopeful that will become available in future on the NHS, but it is likely to be limited to people who are really struggling with recurrent urinary tract infections. It's given as a spray that you put under your tongue once a day for about 3 months. It apparently tastes of pineapple, so as long as you don't mind pineapple, you're fine. There's very little data on their use in urostomy patients, but it is likely that if you're someone struggling with recurrent urinary tract infections, it's something that may be considered and discussed with you as worth trying. In terms of what's on the horizon, well, in terms of testing, there is PCR urine testing. So PCR is a laboratory method to look at fragments of DNA, and bacteria do have DNA. It's a way of doing quick point of care tests to see if we can get more accurate and faster identification of those bacteria. So the culture results take 48 hours. This potentially could give you an answer within the hour. And there's a lot of research groups out there looking at that at the moment. And then probiotics are talked about quite a lot. There is some research which seems to show that they can improve what we call the whole gut microbiome. So the microbiome is the mix of good and bad bacteria that live, and preferably we want the good bacteria that live in your gut, but also they're innately attached to your local immune system in the gut. And the question is, if you take probiotics, which are oral, can that also have a positive effect on the bowel segment in your urostomy, which is effectively isolated from the rest of your gastrointestinal tract in terms of the bowel mucosa itself, but of course it still shares a blood supply with the rest of your bowels. So and it also shares a lymphatic supply, so an immune system drainage. So there's a lot of work going on to see if actually taking probiotics can improve things for the urostomy bowel segment. And again, I would say that they're unlikely to harm you. So taking a probiotic supplement in your diet, or one of these drinks which have these live bacteria in, is unlikely to do you any harm. And if you are struggling with recurrent UTIs, it might just help a little. So my final thoughts: UTI has been a long neglected area of research. It's always been put down to one of those things, and it just happens. And I think the focus has for a long time been on women who get UTIs, because women do tend to get them more than men. Although men do suffer with them, and it was always put down for many decades as, oh well, just one of those things, women get it and they just need to put up with it. But of course that is starting to change. We do know men suffer with UTIs. We do know that people without functioning bladders suffer with UTIs, and that's not acceptable. We need to look at how we can improve things. Thankfully, the problems with antimicrobial resistance, I say thankfully, that sounds wrong, but because of the problem with antimicrobial resistance, there's now a greater emphasis on antimicrobial stewardship, and that is leading and driving the research and the interest in funding this research. So we've got to do more to improve our use of antibiotics. When they're needed, they really are needed, and they should be used appropriately, but they should be avoided when they're not needed. And we should sort of do our utmost to try and see if we can develop some more effective non-antibiotic treatments. And then the aim really, I think, overall is to try to prevent recurrent UTIs from ever developing in the first place. And a lot of what we do at the Urology Foundation is about education and awareness in society, and breaking taboos around toileting, getting people to talk about these things that people, these areas of healthcare that people find embarrassing, and work to improve things like public toilet facilities and facilities at work. It's really important to understand your personalised risk when it comes to urostomy and UTI, and be aware of the potential signs and symptoms of a UTI. And we really would need sort of keep pushing for rapid and effective intervention in the community, because it's better. You need better access to timely assessment and clinically validated tests, as well as not neglecting basic measures, antibiotics when required, early onward referral if recurrent UTI seems to be developing. And in that respect, there are more and more specialist multidisciplinary UTI clinics being developed throughout the country, particularly within urology departments, and that will lead to better healthcare, better outcomes. Because overall, at the end of the day, it's the patient on the end of all this that has to deal with it and suffers the consequence. So if we can do anything to reduce the sort of personal, social and economic impacts of it, then we should be doing that. So that's the end of my presentation. I shall hand back over to Brian. I'll stop sharing my screen as well.
Thanks, Mary. Excuse me. Thanks, Mary. That's been extremely useful, and I think covered quite a lot of the areas that we hoped it would. If anybody's got any questions, we've got one question in the bag at the moment, but I'll leave that till the end. When I was introducing people at the beginning, I forgot to mention Helen Woolley, who, as a urostomy patient, has recorded a short video of her experience that we'll move on to next, and then come back to Helen to take a look at it from the stoma nurse perspective, I think. Thank you. Okay, Scott, thank you.
Hello, my name's Helen Woolley. I've had my urostomy since 2006, which was a long time ago, and my life has got considerably better as a result. And in the early days, I knew really nothing about urostomies. I didn't know anyone else with one. I didn't know about any branch meetings, or I don't know whether that Facebook existed or if there were any groups or anything. So I was sort of in the dark, and I think my GP practice was in the dark as well, as not every GP practice has many or any urostomy patients. But so in the early days, for some reason, I was asked to bring a sample of my urine, and they dipped it and decided that I had an infection. And here's an antibiotic, go and take that, take the full course. And I think then I was asked to produce another specimen so that they could check it had gone. And this time it was a slightly different sort of infection, apparently. So they gave me a different lot of antibiotics. And this happened for quite a lot of time. There would be one supposed infection, then a course of antibiotics, and then it would go on to another, and then another. And finally, it sort of dawned on both of us that really this was a bit silly. And it was agreed that they would only prescribe an antibiotic if I had additional symptoms, so not just the results of dipping my urine. And after that, I didn't have half as many infections. I mean, I can't remember how many I've had, but not that many. I was sort of worried at the time with these infections. I was worried that maybe I was doing something wrong. Maybe I wasn't cleaning the night bag properly. Maybe I was just a dirty person. I honestly had no idea. But it was explained to me that because the stoma is made out of part of the bowel, it's bound to have bacteria, and these will always show up in the urine. And that's why when we do give a sample, we need to label it that it's come via urostomy, so that they know that it's not going to be like coming from a standard bladder. I wasn't sure how to check if I had a UTI. Sometimes I would sort of look and see whether it looked a bit murky. But my method these days is to, if I need to provide a sample, a specimen, which I'll then take to the doctors, I will have a shower without a bag on to sort of make sure I'm clean. I'll put on a totally new urostomy bag, and I'll then wait just for long enough to be able to get enough urine to then go into the specimen bottle. And so that doesn't usually take that long, but depends on what time of day it is, or whether I've had my cup of tea or whatever. But it's rather quicker than, if I was to try and catch urine coming out to the stoma directly, because it might just dribble or not do nothing, or else it might spurt all over the place. So for me, I found that the best way. And one of the things I have had to do is to make sure that the little vial, I've written via a urostomy on it, to make sure that they can then make allowances and check what sort of infection there is, if at all. I also found out that if you're going to a hospital or a clinic appointment and you know that they're likely to be asking for a urine specimen, it's much easiest to get yourself all sorted out before you go. Had your shower, you've got your clean bag on, you've taken your specimen all labelled up, and you can give it to the nurses in the clinic. Other times when I've suddenly been asked for a sample, I hadn't expected that, I've then had to hang about, wait, and be patting my stomach and have I got enough urine in there, drinking lots of little cups of water, and then perhaps an hour later I've got enough. Because stomas don't always behave on a regular basis. They take their time. So yeah, being prepared with one I've made earlier, as per Blue Peter, that works for me. So yes, I think I mentioned that I was a bit worried early on that I wasn't doing things correctly, and I went to a meeting. I think it was at Coloplast headquarters one time when we were having going around their factory, well, distribution centre more likely. And there was a nurse, I think, connected to the Urostomy Association there, and there was a sort of question and answer session. And we were asking things like, how long should I keep a night bag on for? I have to explain that. How many days should I use it for? You know, I don't use a sort of a disposable one. I use one that can wash out every day and then replace with a new one after a while. And the stoma nurse at that time said she recommended 10 days would be, you know, would be probably enough. And so that's what I tend to do. But I do know that many people with a urostomy change more frequently, or they use very strict measures to clean out the bag, to use vinegars, to leave it to steep, to, you know, they take it very seriously, as they should. But it would be really useful to perhaps get a more definitive answer about this. But I don't think it's, you know, whether we clean our bags, our night bags, properly that gives us a UTI or not. There's plenty of other reasons. One of them can be dehydration, and I think that may have been the cause of an infection that I've had recently, where I just wasn't drinking enough. Another might be that, you know, there's some sort of problem where the bag isn't, where the urine isn't sort of draining very quickly, or it's got caught for some reason, and you know, that can cause the bacteria to grow. So it's not our faults, it's not something that we're doing wrong. And some people just don't get UTIs, whether that's through excellent hygiene or whether it's luck, I don't know. But yeah, it's not something that we should panic about if we do get them. And another thing that I think has been important that I've thought about over the years is when discussing possible infections with doctors, is to ensure that we've talked about the symptoms rather than just, you know, using looking at the results of dipping the urine. I mean, for me recently, I felt rather unwell. I had nausea, I was vomiting and had diarrhea. I got the shakes, the sort of tremors, and I was feeling clammy one minute and sort of cold the next, and felt very unwell. And that just turned out to be an infection that I think may have gone to my kidneys. And I think that's probably all I can say about UTIs, really. They're not too frightening. They can be treated, but we don't need to panic. Anyway, thank you.
Very good. I'll come back to my experience of UTIs in a few minutes. Ellen, is there anything that you'd like to add to that from a stoma nurse perspective?
I mean, I think, thank you, Helen. I mean, it's really good to hear your experiences. I think the main thing that comes out of that, you know, really valuable insight is that, you know, I think that if you're a person, and as Mary said, you know, you're unlucky enough to be in that category that get recurrent UTIs, and we don't know why that is, you know, your system seems to cope with it better than others. And then, you know, so if you're a person who is experiencing UTIs, then the best way always is to get the sterile sample, because we have to absolutely be certain that the urine that is obtained is not in any way contaminated by external events. So understand the, you know, how you describe, Helen, the, you know, the how you do it is I can totally get that. And sometimes the the technique of learning to put the catheter in, or if a nurse is around to do it for you, then it can actually expedite the urine flow from the loop of bowel, and you get the sample quite quickly. But that's not always possible. I realize that. But I think in the case of, if you are a person who has recurrent UTIs and we really need to know what's going on, then the clean patch direct into the bottle, or a sterile sample through a catheter, is always the best. And that would be what I would say with that regard. Do you want me to cover night drainage?
Yes, please. Yeah.
Yeah, okay. So again, Helen's right. You know, what you do and don't do with your night drainage probably is neither here nor there with creating UTIs, because again, if you're in that category and you're all right and it works for you, I'm a great proponent of being in the routine that works for you. But again, I think with night drainage, if you're in that category of getting a lot of UTIs, or, you know, enough that it's bothering you, to me, you need to be looking to change your bag. Sorry, I'm getting some pings here. Twice a week. So I would say every sort of every third day. And cleaning it is just warm soapy water, hot warm soapy water, rinse it through, rinse it with water and let it air dry. I'm not sure the evidence is there to soak it in antiseptics and things like that. I think you know, whatever you're used to, and it works for you, do it. And obviously we've got to balance that against environmental concerns, which I totally, you know, we're wanting to get to net zero and all of this, and it's really important. But I think if we're looking to troubleshoot, we've got to look at these things and think, how can I improve it? Maybe if I, you know, make sure your night drainage is, you know, lower than, so that it's draining well, there's no chance of backflow, and remembering that your appliances do have a non-return valve, you know, so, you know, don't worry so much about that. But as long as it's flowing and you're changing it routinely, I think personally 10 days is it's pushing it a bit far, in my opinion, as a stoma nurse.
Okay. Thanks, Helen. When do you think someone should approach a stoma nurse then, if they feel that they've got a UTI?
Yeah, it's such a good question. I think stoma nurses in general are great, you know, for you know, skin concerns, all the problems, you know, fitment of the device, maybe you've had some skin problems, fantastic. But up and down the country, there's a great variation on the levels of knowledge of stoma nurses. So when you do the stoma nurse course, it's really interesting because most stomas are bowel stomas, ileostomies and colostomies. So a lot of the nurses learn about those types of stomas. So, you know, urostomies, I was always told, were, you know, they're tricky. You're tricky, you lot. You know, you're in the minority, and the knowledge isn't always there. So what I'm trying to say is, everything about stoma care that is universal, your stoma nurse is a great source of help. I think if you're lucky enough to have a stoma nurse who has a urology background, fantastic. I think from my point of view, I think if you still have a relationship with your urology department or your urologist, and you can contact the secretaries, or you might have a direct line into the hospital. And no, not everybody does. So it's very, very, very different up and down the country. If you don't, then I would be definitely speaking to your GP, obviously, as your first line, because if you've got a UTI, and as Helen says, and you've got the shakes and the teeth are chattering in the head, I mean, that needs to be seen to. It's probably moved into your kidneys and you need your emergency urgent help. But if you haven't got that direct line to the urology department, ask your GP to refer you in. And as Mary mentioned, these specialist UTI clinics are starting to spring up. You know, I know there's one in the northeast, there's one in London, there's definitely one in Bristol. I'm not sure elsewhere. It would be really useful to find out. So there's a few things there. GP, your stoma nurse for your basics, GP for a suspected infection, and then if it's recurrent, definitely asked to be re-referred back into the system where you can access urology nurses, your consultant, and maybe specialised UTI clinics.
Thanks, Ron, for that, Helen. Mary, you've got your hand up. Yeah.
Yes, yeah, thank you. I've also noticed Adele's question, which I will answer as well, Adele. But I just wanted to back up what Helen was saying there, and add an extra thing about night bags. So I agree entirely with Helen. If you're struggling with recurrent UTIs, then you probably should be changing it more regularly, so every 3 days. But if, you know, if in your normal routine is that you change it every week and it works for you and you're not running into trouble with recurrent UTIs, then that's fine. But we were both just at the ACP conference in Liverpool. That's the Association for Continence Practitioners, just yesterday and the day before. And a lady there from the Isle of Man raised an issue with the fact that a lot of companies that make night bags now put on them that they're for single use, which means that you use them once and you throw them away, which has huge environmental impacts as well. But there is a difference between what should be single use, used once and thrown away, and what should be single person use, i.e. the same person can reuse that for a period of time before getting rid of it. And it's sort of sloppy in terms of the manufacturing sort of stamps that are put on these products, because the trouble is then that NHS procurement and NHS services can feel like they are going against the manufacturer's advice for their particular product. And so you might find that you're being prescribed night bags and being told this particular bag has to be single use only. You have to use one every day, every night. But actually that's semantics, and you're not going to come to any harm if you use it for longer than that, if you use it for your usual 7 days or whatever you use. So I just wanted to add that. Adele, you've put a really interesting question about blue-purple bag syndrome. So Adele has said that a stoma nurse suggested a quick check for infection, which came back negative, so said not to worry about it, it's just one of those things. Yeah, it's a really interesting one, and it's quite alarming when it happens, when your stoma bag or your night bag turns, you know, the urine looks bright purpley blue. The reason she suggested a check for an infection is one of the things that can cause that discoloration to the urine is a Pseudomonas bug, and Pseudomonas as a UTI is a really nasty one to get. But Pseudomonas is present in lots of things, and it might just be contamination of your bag rather than actually coming from inside your ileal conduit. So if you're well and it just happens as a one-off every so often, I wouldn't worry about it, but I can understand why they wanted to check to rule out Pseudomonas infection. The reason it turns the bag a colour is that there's a chemical reaction between it and the chemicals in the plastic bag. So not only does it make it look like not only does your urine look purpley blue, but your bag can get stained that colour as well. So I hope that answers that for you, Adele.
Thanks, Mary. There is another question from Mary Milner. Mary doesn't use a night bag at all, and she's saying as a UA volunteer, is there any specific reason why we should always recommend using night bags?
No, not at all. I know many of my patients chose not to. And you know, if you're a sort of wakeful person where you would get up in the night and you would prefer to empty your bag, that's absolutely fine, because you know you might not want the sort of complication of the wires and turning over sofa and bed, and you know, it's definitely an art, isn't it, Brian, to
It
get
is
the
very
right
much so.
drainage right. And you know, a lot of urostomists decide that they just don't want to go down that route, and there is a non-return valve, so don't worry. You know, the urine can't really get back on and into the stoma. So as long as you, unless if you're a deep sleeper and you're going to wake up with an explosion in the next morning, I wouldn't recommend it. But if you are quite happy with thinking, oh, I'll just have a little feel, I'm going to pop up, empty my bag, jump back into bed, and let's not bother with the night bag, I'm 100% supportive of that.
Okay, Mary, you
I
got
would I'd add probably just one caveat, which if you're in the middle of an active UTI and you are feeling or you're in a run of recurrent UTIs, then I probably would say do it, because although there is a non-return valve, there's always that odd appliance where it doesn't function as it should, and you really want to avoid any reflux of infected urine back in to the urinary tract.
Absolutely.
That's
But I think I think if you're lucky enough not to have the runs of UTIs, I think you're quite happy. You know, you're all right. But as Mary says, if you're wanting to troubleshoot and really try and, you know, prevent anything, then I think that's the way to go, definitely.
Thanks for that. Scott, we've got a couple of people with a hand up. Can they be allowed to ask questions?
Yeah, we can unmute them, or you can unmute yourselves.
Thank you. First of all, very many thanks to Mary, as it was so enlightening. Mary Garthwaite, there you are. Just a couple of very quick questions. I'm in London. There isn't a close association in London. I'm 84, so it's hard for me to get around. Have you any advice about how to reduce the mucus production? Because of the mucus, and I change very frequently, and unlike some of the others, I couldn't manage without changing the night bag in the middle of the night. I wouldn't get through to the morning. So could you give advice about that? Because the mucus tends to slide off the appliance, the adhesion, and I've had a couple of embarrassing public leaks. Have you any advice about my stoma nurse tried to say, you know, lots of cranberry juice and lots of blueberries, and I do that like they're going out of fashion. So if you have any advice, I'd really appreciate that, and thank you.
That's a really interesting question, and it's another one a bit in the same ilk, that we don't know why some people suffer really badly with recurrent UTIs when they've got a urostomy and others don't. We really don't understand why some people produce an awful lot of mucus from their bowel segment and others don't, and it's probably something to do with your bowel, the quality of your bowel itself.
Yeah, diet maybe, or something. I don't know.
So in terms of advice, there are things you can try. None of it, I can't give you a magic answer.
No.
But diet is one of the things that can definitely influence it. And it's not just what you eat, but it's also things that can change the acidity of your urine. So you know, if you take things that can make your urine quite acidic, so sort of dietary things that you would tend to avoid would be things like, well, starting with drinks, you'd avoid citrus, you'd avoid white wine. Can change your urine acidity quite dramatically.
I've stopped drinking since I had the thing, because of the, you know, I take so much water.
Right. So you have got that, but there, so you can look at your diet and you can keep a diary and see if there are any patterns. Your hydration status will affect it to a degree. The stoma nurse saying, and Helen might want to come in here, but saying cranberry and blueberry to you, that cranberry definitely from a UTI point of view, I've not heard of it in terms of reducing mucus production, although if it does work for some people, then why not? So you could try cranberry. If you want to increase your hydration and do cranberry at the same time, I would make one plea. If you do drink cranberry juice, it's incredibly full of sugar, and it's also very strong. And so you would dilute it 50-50 with water and only have 1 glass a day of it, and you
What
still
about
get
what about the no added sugar version?
yeah, no added sugar is better if you don't
But
mind
still
that.
dilute,
Yeah,
I was,
still
if I can just jump in there,
Yeah.
I sort of working with a nutritionist over many years, and she recommended the use of actual cranberry powder, because then you dilute it. You dilute it and you don't get any sugar, you get no additives. So it's
yeah, it's
Thank you.
yeah, you have to be a little bit skeptical of the sort of ocean spray cranberry drink,
Yeah.
because
Oh yeah, yeah.
they did fund a lot of the research into its effects in UTI, the initial research into UTIs and its
Oh,
effects,
right.
but it definitely does have an effect for UTI. If it works for reducing mucus, then great. So it's worth.
I wondered if milk. I do love milk, and I have because I can't take the osteoporosis meds that they would like me to take because they can damage your kidneys, so I don't take them. I do use full fat milk, and I did wonder if milk was a hazard.
Well,
Yeah.
You could do an experiment where you cut it out for a week, or
See what happens.
still 2 weeks and see what happens, and then slowly introduce it again if it has.
I don't want to use up your time, because there'd be other people wanting.
Sorry, the only last question I would ask you though is, do you suffer with general bowel problems? Do you suffer with
since the surgery, I've got terrible bowel problems since the surgery. It's always been extremely difficult to go. Like Mike, I have a massive peristomal hernia, which they reckon can't be treated except in an emergency. And I've been searching also for supportive but not too heavyweight stoma support. And I've bought things, and my stoma nurse has given me things, and I don't find any of them comfortable. So that's another project for another day. I know that.
But it is worth looking after your general gut health, because there is a theory, what I was mentioned about a whole gut microbiome, but if you've got an irritable bowel, then you may, if your bowel is producing more mucus, even though you don't notice it because it mixes in with your feces, your urostomy segment might also be doing that, because your bowel
so probiotics maybe, right?
Yes.
Thank you. I don't want to hog the time. Thank you.
Okay. Thanks,
Thank
Linda.
you.
One quick point on mucus. I've had my urostomy now 13 years, and I always use a 2-piece bag. And I take the bag off at night and turn it sideways to point down to the night bag, so the flow's working well. And while I do that, I also clean the mucus away from the stoma, and again in the morning when I turn it back again, so it stops the mucus clogging the bag up or anything of that sort. So a 2-piece bag might suit, it might not, but it might just one of those little things that might help.
That's a good top tip.
I'll not go into my experience with UTIs now, because I've only had one in about 20 years, but there we go. But to thank everybody, particularly Mary, Helen, and the other Helen, for the presentations. We've gone on a little bit longer than we usually do, but I think it's been very useful, and obviously with the questions coming, then people have benefited from it. So thanks very much indeed. We're trying an experiment tonight. When you log out of Zoom, there may well be, fingers crossed, there may well be like an evaluation form there to say what you thought about the presentation, so that we can continually improve things and move on. There's also a link in chat that Scott's put in there, if that doesn't pop up, to put your comments in. But if
just in case, if you could copy it, it'd be great.
Okay. So yeah, thanks for all your help in presenting, and hope we can help the people that are still suffering. Thanks very much indeed, Mary and Helen, and the other Helen. Thanks everybody.
Thank you. Thanks for organising.
Bye bye. Bye bye.
Bye bye.
Bye.